Hello, everyone. Welcome to Stanford Care Center for Asian Health Research and Education monthly community health talk series. My name is Amy Tao, and I'm a first year medical student here at Stanford. We are very pleased to bring you this educational series co-sponsored by Stanford Care, the Stanford Health Library, and the Vincent V.C. Wu Memorial Foundation. So today's program is essentially meaningful as it marks the inaugural kickoff of our special series on AI in Asian health. And the title of today's talk is AI and the Future of Asian Health, Advancing Precision Medicine through Human Insight and Technology. Throughout this special series, we will explore how artificial intelligence is transforming medicine and how these advances can help address the unique health record needs of Asian and Asian American communities. We are very honored to welcome Dr. Jonathan Chen today, physician scientist and biomedical informatics leader at Stanford University and director of AI at Stanford Care. Dr. Chen leads a research group that integrates human expertise with AI to improve clinical decision making and patient outcomes. His work bridges data science, medical education, and real-world care delivery to ensure that AI-driven innovations enhances rather than replace the human touch in medicine. So, in today's talk, Dr. Chen will explore how AI and human insight can work together to advance precision medicine, improve diagnosis and prevention, and address the health disparities affecting Asian populations. He will also discuss the importance of responsible, equitable implementation, particularly in communities historically underrepresented in medical data. Please join me in welcoming Dr. Jonathan Chen.
Excellent, student Dr. Tao. Don't go too far. Embrace you in a little icebreaker here. I see people still logging in. It's kind of a crazy world we're living in. Also, we haven't realized I'm talking out of a hotel room. I'm over at the Alice Walton School of Medicine, teaching other educators as well as trying to get the word out on so many different things in a rapidly changing world. I mean, with AI, is it like Terminator now? Is it HAL 9000 taking over the world? And what kind of analogies can we think of at this point? Just as a random thing, I don't know. Amy, can you think of like what's one of your favorite movies that really left an impression of you about your imagining what the future might hold one day?
So, because like we have a lot of like programming codes today. So
Mhm.
while I'm also had a lot of experience like programming, sometimes I'm scared of like, like the AI or things will take over, like replace all of us human beings in the future. So one of the movie I really liked before, it's called Source Code. And it's
Oh yeah.
about yeah, it's
Uh-huh.
about like the military program. Then they send like the main character back time to someone's residual memory before they like gonna die in a bomb like accident, and they're trying to have the character figure out like who is the bomber. So I think the most interesting part about that is like you think about the source code and the programming help the main character going back. Is it just like a simulation, or is he creating like,
Mm-hmm.
like a new story or like a new world? And
Mm-hmm.
maybe like the things happening today is also kind of like similar to that. But there's
Yeah,
no answer to that.
that was a super fun movie. It's all about like recreating things and what can you tell.
Yeah.
Like now we'll talk about your social media feed. It's half of it's all just AI generated content. You can barely tell what's reality anymore.
Yeah. Yeah.
Literally, I'm looking for a random number, but just before you do it, I'm gonna write something down here just for fun here. Do you know you can either pick a random number up to 100, or could you just like tell me like how old do you think you are when you saw that movie?
How old?
Or
I
you can just
think
pick a random number up to 100.
I think it's like 21.
21.
Yeah.
Okay. So, that was a while ago. Now I'm trying to
Hmm.
reconstruct, how old must student Dr. Tao have been? So, a lot of things can seem random and arbitrary. Sometimes it's actually very predictable patterns. If you look at modern language models and AI systems, it's kind of like they just digested the internet and found very predictable patterns. And it's just strange that this phenomena emerges. I mean, if you guys ever seen like Google Trends, just looks for like the most common things that people search for. It's actually not random. And
Hmm.
if I can get my window up here, For example, I don't know, some of the most popular movies over time. And then you picked 21. What did you, what is the 21st, one
Oh,
of the most
Inception.
common movies? That's kind of interesting. You could have picked any number, and yet I believe you might have been thinking about Inception.
Ooh, my gosh.
Random,
This is,
random.
yeah.
Okay, okay. Who knows? Who knows what are predictable patterns? Let's start diving in, and then we will see where the rest of this goes. All right. I'm going to start with a brief 1 minute introduction video and think about what's real and what's not. All right.
Hi, everyone. This is Jonathan Chen, and I can't wait to see you in person for a compelling and fun session together.
Oh, wait, that wasn't me. That was just an AI-generated avatar. Just a little preview of the fun and provocative learning we'll have together.
Wait a second. Wait a second. That wasn't me either. I'm the real Jonathan Chen. Or am I? How would you know? How could you possibly tell the difference? There's so many complex things in the world, you can't tell the difference. Rubik's Cube, one of the most complex problems, and very few people have solved one. It looks like a toy, but actually, once you get your hands on it, like medicine, like science, it's way more complex than you expect. But if you watch close, do not blink, it might be able to be solved much more rapidly than you expect. Some of you might have missed that, or I know what you're thinking is like, this got to be a trick cube or something. There must be rubber bands in here. There must be a motor. I bet there's a reset button where you just click on the side and then it just solves itself. That's not what's happening. That's not what's happening. I know what you think. Maybe there's a switch in here where it can instantly go from like solved to unsolved, solved to unsolved. That's not what's happening. You must consider the other possibility. Was this all just an illusion? Was this thing actually mixed up in all six sides? It absolutely was. Even though there's no basis for you to prove it, if we were here in person, we could do this. But again, you apply very deliberate techniques, even a very complex problem is solvable much more rapidly than you might expect. That's not magic. It's not magic. It's actually just algorithms very deliberately applied to a complex problem. Let's dive back in here. All right, we're going to go into where hopefully we're all logged in now. We can start diving into the core content, some acknowledgments, some learning objectives. I'm going to start with a little bit of a story to motivate why, beyond my general AI and medicine concepts, but why I motivated this on a very kind of personal level about Asian American health as well. This is me when I was, I don't know, 13 years old or something. I don't know about the rest of y'all, but if somebody asked you, I don't know, Amy, maybe did you know you wanted to be a doctor when you were 13 years old, or you had no idea?
No, I don't think so.
Okay. Well, if someone asked you when you were 13 years old, what would you have said you wanted to be?
I think at that time I want to be a supermarket manager because I want all the food in the supermarket.
Okay, okay, that's pretty good. That's pretty good. If you had asked me at the time, I would have said, I don't know, I'll be a stand-up comedian because I like to make people laugh. I don't know, I'll be an architect. I have no idea. I mean, and who cares? I'm like a kid, right? Why would I know? A
Yeah.
very unusual thing. I started college at a usually young age. I started college when I was 13 years old. And so, I really did have to think about that. And then, of course, my parents wanted me to be a doctor. I'm like, sure. I mean, I don't know any better. Even though my dad's an electrical engineer, I'm really much more a computer nerd. And I was heading towards there, and I ended up at the last minute prepping for medical school. Is like, I'm not ready to commit my life to this. I'm way too young for this. And you got to be this passion for being a healer. I'm just a kid basically. So I was a software engineer during the dot-com bubble and burst. And that was actually my first job out of college. And that was very eye-opening. It's like, oh, you can make a lot of money in industry. And I did. But also you can see like it's very mercenary and for profit and maybe wasn't really the values and career I was looking for. It's just a different dynamic. So I did a joint MD PhD program. The PhD is computer science. I like to say I got the PhD to work on interesting computer nerd problems, and I got the MD so I could understand real problems applied to human health. And that combination, I didn't know what it meant at the time, but I figured it'd be compelling. And it was because I decided this is going to be really hard, but I don't want to regret how I spend my time. And I spent some time in industry making money and then getting laid off and then getting another job. And like, it's fine, but I kind of felt like it was I spending my time the way I wanted to. And it's been a long road, and also it's also been very good, but also I really had that concept really put to the test. Do I regret how I spend my time? So when I was a fellow after my MD, my PhD, my residency training, 12 plus years later, I was doing my research fellowship. At my time, my mom called me and said, "Oh, he has some abdominal pain. He got a scan. He looks like he has cancer. He got colon cancer, and it was already spread to the liver by then." And before long, I mean, he got treatment, but he died of cancer within 6 months of the diagnosis. And so that really challenged me. It's like, oh, am I really doing what matters to me? Do I regret how I spend my time? And it was actually obviously a sad situation, but reassuring to me. It's like, I totally feel good about what I do now. It's so hard. It's so stressful. It is an absolute slog, but I know I'm trying to do something good and trying to make a difference where I can. And that was a real important aspect of um, there are ways to make money, and I also make money, and that's not the same thing as doing something that where your time matters. Uh, then to accentuate that story a little bit more, it was just a few years after that, my one of my aunts got diagnosed with pancreatic cancer, died within a month. And then my other aunt diagnosed with pancreatic cancer a year after that and died within 6 months. And then about another year later, then my mom diagnosed with recurrent cholangiocarcinoma. Like, holy crap. Um, Obviously all bizarre, nasty situation. Life happens and we kind of cope with it. At least we're doing things we know that matter to make our time count. Although it also what it really begs was like, what is going on with my family, right? I clearly have some really nasty, bizarre familial syndrome with cancer. There's even more I haven't even mentioned yet. There's just there are 4 deaths in a row within 4 years, which was crazy. I like got unusually familiar with how to run a funeral by the end of it. And so what do you do? It's like, well, some of my cousins, they said, well, we're gonna go the genetic testing. We got to find what bad genes are in family that's causing this to happen. They did the special genetic testing, and what did it show? Showed nothing. Showed nothing. Well, it didn't show nothing. What it showed was variants of unknown significance. Like, I don't know, your family has different genes, but as Latha Palaniappan will remind us, even though Asians represent 60% of the world's population, we're only in like 10% of the clinical databases and trials. Like, there's not that much studying done here, even though we're this disproportionate population. So they don't even know what to do with our genes. There clearly is something wrong there, but they can't even identify what it is because there's not enough data. There's not enough study in this area. So in practice, also, what do you do in the meantime? My cousin, whose mom died in a similar way, he went to Walter Park, one of our Stanford gastroenterologists. He's a pancreas specialist. And so he made up a protocol. It says, well, given that family history, there's clearly something going on. There's no standard research or data to tell us what to do, but I will do an endoscopic ultrasound. I'll surveil and keep a track and make sure things are okay. So that's great if you can come to a Stanford and you have the Walter Park, this world specialist who can make up a protocol, but not everybody has access to that, right? So now here's sort of like where I'm hoping AI can make a difference. There are some cases where you just need an in-person consult. If you want a colonoscopy, if you need a surgery, like you need to go see a surgeon. Like I don't care how much AI you give me, I'm not going to do that for you. But sometimes, hey, you know what? An electronic consultation is good enough, right? You can email a specialist in a question, they'll email you back an answer within a few days. Or does this sound crazy now? A few years ago, when I've worked on this for 7, 8 years, it would have sounded crazy. Now it seems almost obvious. What if we had fully automated guides that could give you consultation medical advice, even without, you don't even have to email a person. It's like you can just talk to a computer. Could you really do that? Could you talk to a computer to get medical advice? Well, I don't know. Here's some headlines that featured some of the work we did in the prior years. It says AI defeats doctors at diagnosis. Look, I would not have written that headline myself, but it did trigger a lot of very angry people to read the articles to kind of serve its purpose. What does it mean now in the world when ChatGPT and multiple other models can pass law exams, business exams, medical exams? Many educators, even at Stanford, said, oh my gosh, we must ban this technology. After all, when student Dr. Tao gets a degree, we want her to actually know medicine, not just how to use a bot, right? Wait, I don't know. What should we be teaching student Dr. Tao? What do you want out of your doctors? What do you think matters? It's a very challenging question. What is the point of a doctor if now AI can even do diagnose and answer all sorts of complex questions? A really existential question for our professional identity. What does it mean and matter? While also prioritizing, really, as long as patients get the best care, that's what should matter. But how do you reconcile that with very shockingly advancing AI capabilities? My most cited paper from 7, 8 years ago, I said machine learning is way overhyped. Like it's a cool tool, but people are way overselling what it can do. Versus now these generative AI, large language model, chatbot AI systems, like holy crap! When I first saw these GPT-4 emerging, I'm like this is disruptive technology. This is like the internet just got invented. It really is going to change everything. Because here's a broader theme I want you to think about. Think not just about where you are, but like where we are going, because the future is coming incredibly fast right now. This is a chart showing over time how well different chatbot language model AI systems have done on answering medical questions, the kind of things that student Dr. Tao has to study all the time. I had students working on this 6 years ago, working these transformer systems. At the time, like 33, 35% accuracy. Oh, I mean, that's not very good. I stopped paying attention to this technology. It didn't seem very useful. And then what happened a few years ago? ChatGPT emerged, GPT 3.5, the first version, 60% out of the box, no special tuning. You can kind of barely pass even a medical exam. That's crazy. Some of my colleagues said at the time, well, if you want a doctor who barely passes medical school, you can talk to this chatbot. This thing's not smarter than me. And I thought, boy, is that the wrong way to think about this? A few years ago, this technology was unusable. Now it's kind of barely passing. It's really not hard to project where we're going. Indeed, MedPalm, MedPalm 2, GPT-4, multiple systems emerge, and now they can handily pass this exam. Better than your average doctor, better than your above average doctor. And by the way, if you'll notice, I stopped updating this chart over 2 years ago, a year ago, because now all the frontier models are handily passing the exam, getting 90+%. Open Evidence put out a press release some months ago. Their thing is now getting 100% on these type of exams. Hang on. What is this? Just answering a bunch of multiple choice questions. Nobody's job is just answer multiple choice questions all day, except for student Dr. Tao. That's what she has to do all the time. She has to take multiple choice questions all day. That's her job right now. So to be fair, yeah, like no, I bet you've seen some of these, yeah, in your classes. We have complex, nuanced reasoning, these complex clinical cases. Don't worry about all the text, but basically it's kind of describing a patient scenario with relevant information and irrelevant information too, right? The patient doesn't know which parts are relevant. Part of the job is to put the story together and make it make sense. And we don't ask multiple choice questions. We say, summarize this case in 200 words, give a differential diagnosis. What do you think it could be? And explain your reasoning for why you think it's the pros and cons for each choice. And here's the key to unlocking the next phase. See, computer scientists, we like multiple choice questions because it's very easy to grade, even though it's kind of very separate from reality, right? It's actually your English teacher who knows how to unlock the next phase of AI technology, right? Because they can read your essay, the paragraphs, the images generated that come out of an AI system and grade it the way you would grade a student or a person because they've got a rubric. If you write a little essay, I can read it and I'll look for these key elements. And if you do these correct things, I'll give you 1 point or 2 points for each thing. There's a way to give a quantitative feedback to even a complex reasoning phenomena like this. So we've done several studies like this. So I'm just going to highlight just a couple of them. But here's one concrete example. We did a randomized control study, real doctors going through a battery of complex diagnostic dilemmas, and it's not multiple choice. This is expert consensus reasoning to grade through. They have to say their differential diagnosis and the pros and cons and what are their next steps. We randomized half of doctors to go through these cases, and we said you can use the usual internet. You can go to up-to-date Google, PubMed. Just don't talk to an AI chatbot. We randomized the other half of doctors to use GPT-4, and compared to this score distribution, it turns out, did about the same. They did about the same, which is strange. That is not what we were expecting. Because it turns out if you just ask GPT-4 by itself, it actually outscores all of the doctors, including the doctors who have access to GPT-4. Like, what is going on here? This really flies in the face of the fundamental theorem of informatics. Human plus computer, when combined, will deliver better results than either alone. Doesn't that sound so good? I used to say that as the closing line for my keynotes for years. I don't say that anymore because I'm unsure right now. This human in the loop in the middle kind of seems to be slowing the computer down. Like maybe it's just get out of the way and let the robots take over already. I don't know, student Dr. Tao, why are you even still in school anymore at this point? Maybe the robots will just take it all over. We'll have to see. We'll talk about it. I actually think it's a couple things. For one, in some cases, like a calculator is just better at calculation, and you should just let the computer do something it's better at than a human will be, like memorizing 1,000 facts. The computer's just always going to be better at that. The other part is, again, education is how we unlock the next phase. This is a study where we highlighted how if you look at the doctors who participate in our study, a third of them had never used a chatbot before in their life. So they had they just didn't even know what it was. They didn't understand how to use it. Another third had used it maybe once or two times. Some of the people here figured out you can like copy and paste the whole story in and kind of get the follow up. and ask follow-up questions, which maybe now seems normal. 3, 4 years ago, that felt weird. You did not expect that you could interact with a computer that way. Some people summarized it before asking the computer a question. A lot of people treated these chatbots as if they were like a search engine. Google search. What is causes of eye pain? That's a very limited interaction. And then there's a big chunk was blank. People who just did not use the AI to help them at all. Is like, I don't know what this is. I don't need this thing. I don't even want to learn how to use it. I'm just going to ask based on what I know. So that's a limitation if they're not really taking advantage of the capabilities available. If you want to understand more about what explains all this phenomenon, just read all these articles. I've been writing about this, and we're studying this area for over a decade. Okay, look, I know what you're thinking. I don't have time to read all this. This is hundreds of pages of information. If you scan this QR code, you go to the State of Clinical AI report, there's literally 130 slides where we summarize just the last year of major clinical AI research breakthroughs. I mean, can't someone just, or something, just read and digest all of this for me? I don't know, student Dr. Tao, if you're doing this, if your classes are ready, right, to review all your lecture slides. What if you just uploaded all of those articles to a tool like Notebook LM, right? Yeah.
Yeah, we're
Uh,
using that.
so you should use it. You should use it. Be careful though. That doesn't mean it does the work for you. It's at some point you still have to do the work. Otherwise, this learning doesn't happen. But yeah, upload all these articles. It'll create a summary, an FAQ, generate an audio overview. You can listen to a podcast, and boy, does it sound real that explains it. Or I try to generate a video overview. And here I'm going to play just a 1 minute snippet of the video overview that was generated when I am using this Notebook LM tool.
But then came the twist. You see, the researchers also had the LLM try to solve the cases all by itself. Its score? A stunning 92%. The AI, working completely alone, dramatically outperformed both groups of human doctors. So this leaves us with this head-scratcher of a paradox. The AI itself is incredibly capable, right? Yet giving it to experts didn't help them one bit. So what is going on here? This really forces us to ask the most important question of all. If the AI is so smart, why didn't it make the doctors who used it any smarter? Why the huge disconnect? Well, the answer seems to be in the really tricky nature of human-AI collaboration. First, these tools are super sensitive to how you ask a question, what's called the prompt. Second, you can't just drop a brand new tool into a doctor's incredibly complex workflow and expect it to just magically fit. But probably the biggest issue is something called the AI supervisor fallacy. It's this flawed assumption that a busy clinician can, or even should, spend their precious time double-checking an AI's work for really subtle errors.
That's a very good summary and commentary on the work. And just again to reemphasize for those who didn't get it right, I didn't make these slides. I didn't write that script. I certainly did not say those words. It's just kind of incredibly powerful, all these kind of apparent comprehension and commentary and generation capabilities that 3, 4 years ago would have been like incomprehensible. But that's how quickly things are moving at this point and how you can really learn a lot over time.
But
Let's break it down a little bit more. I'm just probably if Q&A comes in along the way, because I know, or if you guys have commentary, like totally okay. I'm going to keep on going, but feel free to jump in because there's a lot to get into. Let's break this down a little bit further. These are the exact same results I showed you earlier in terms of how doctors do these diagnostic case dilemmas. But we didn't teach them how to use it. We just said, here's the tool, you can use it, and we didn't explain anymore. So maybe it's education. In a follow-up study, we're trying to get to peer review right now. It's this version of GPT-4 in this case, it kind of teaches you how to use it as it goes. It doesn't just say, here, you can type any prompt. It says, hi, I'm a helpful diagnostic assistant. You can ask me any question. You can ask me follow-up. You can give me the whole case vignette. It kind of teaches the person how to use it as it goes. And here's what that ended up shaking out. In the red, again, is how well doctors who have the usual internet available to them, and they do okay. Doctor plus internet is actually very hard to beat. Purple and orange is the doctor plus this custom GPT-4 that kind of teaches them how to use as go. They do better. They do better. Human and computers can collaborate effectively, about the same as GPT-4 by itself in this case. But what's the difference between purple and orange? This is a concept worth breaking down. If AI is so good at all sorts of stuff, what do you do? Do you say, AI, can you write the first draft and then I will edit it? Or do you write the first draft or bullet points and have AI turn that into a final document? It turns out both can work. It turns out both can work, and it can be an effective collaboration, but it leads to different kinds of errors. In both directions, you'll see anchoring bias and sycophancy. Whoever goes first, the second person or the second computer, has a very strong tendency to just agree with the first person. Oh, yes, you're so smart. What a great idea. Yes, what you said makes a lot of sense. Um, because beware that these AI systems, as of right now, they are not designed to be correct or useful. What they are designed to be is engaging. They are optimized to make you want to come back. And it turns out people really like it when somebody or something agrees with them and just says yes all the time. So if you want an actual objective answer to a question, you should not ask AI and tell it what you're thinking because it's probably just going to agree with you. You should say, here's the problem. I don't know what the answer is. What do you think? In fact, I think it could be this other thing. Prove to me why it's not. You have to get it to challenge what you're thinking if you want a more robust answer. Oh, and for those who are paying attention, by the way, GPT-4? What? That's like 2.5 years ago. That's some ancient technology. We've moved on to many different things at this point. GPT 5.2, Claude, Sonnet, Opus, all these things. Here's the exact same data I showed you. Doctor plus usual internet on diagnostic cases with GPT-4 didn't make that much difference. GPT-4 by itself was even better. And then this was cutting edge. We raced to get this done over a year ago, but the scientific peer review. This is going to come out in a major science journal very soon. But like literally the peer review process takes months to up to a year, and the technology moves very much more rapidly than that. But we tested this on the first reasoning models. If a chatbot, a language model, is autocomplete on steroids, it guesses the next word in a sentence in so many words. I'm oversimplifying, but you can think of it that way. A reasoning model is a chatbot that kind of talks to itself for a while before getting back to you, and it just turns out that chain of thought increases its chance of getting a good answer. So, like in this case, here's O1 preview. It kind of looks even better, one of the first reasoning models available. Well, how about management cases? How about management cases? So we have another Nature Medicine paper we dived in. So diagnostic cases like picking, is it pneumonia? Is it Cushing's disease? I mean, this is a classic medical test question that computer scientists like because it's well-formed input, symptoms, output, diagnosis. And in real life in medical practice, this is rarely what you struggle with. Usually the diagnosis is very obvious. There's rare diseases, there's odd presentations that can be a struggle. Most of the time, medicine's like, I know what's going on. The struggle's like, what do I do about it? Patient had a side effect to the medication. Should we just keep on going or do we need to change to something else? Medical error happened in the hospital. How am I going to explain that to the family? Oh, are they well enough to go home or do we need to observe them in the hospital a little bit longer? These are the things you actually struggle with. These are management questions that don't have simple textbook answers. So an AI or a human can't just look up. You really need expert consensus to kind of review all the nuance processes here. And so by design, doctors plus usual internet, they do okay, but not great because this is a very hard test by design. Versus we tried again randomizing doctors with GPT-4 did better. They did do better. Human plus computer can actually collaborate and improve about the same as using as GPT-4 by itself. Oh, and by the way, this would be O1 preview by itself. That was the first reasoning model, which again also is like over a year old at this point. There have been multiple generations of models that have developed and expanded even since then. I don't know, folks. I don't know, folks. Maybe it's just time for us to retire. What do you all think this all means? What should we do? Drop it into the chat or comment if you have a perspective. I see Shreya Patel. She says she's using these tools right now. Another fair thought or critique is like, well, I mean, these are like curated vignettes or case stories. In real life, it's much messier than that. It's not well structured with all the perfect information available, which is true. That's a fair critique. It's isolating a phenomena. I would say to you, though, or to challenge that thought, though, if these vignettes, these case scenarios are so meaningless, why do we make doctors and student doctors like student Dr. Tao here take tests all the time that are based on exactly that? Every license exam, every board certification exam is exactly that. It's all these case vignettes, and you have to answer usually multiple choice questions about them. Nonetheless, we've been expanding further. This is active work, not even published yet, but we're looking at real questions now. Electronic consultation. So what is this? So there's not enough doctors to treat all the patients who need us in every part of the world. It's even worse in other countries, but even in the US, we don't have enough doctors to treat every patient. So if you need to see a specialist, oh, I'm a primary care doctor, I'm going to send you to a specialist. It literally could take you months to get an appointment, assuming you can get it at all. So we have all this electronic consultation system where, well, maybe it'll take 6 months to get an in-person appointment, but I could email the other doctor. They can review your chart. They're never going to meet you in person. They can't physically examine you, but they can examine your information and then email back an answer. And that can be good enough a lot of times to start getting you care within days rather than months. So we went through a battery of these types of real questions. What a real doctor asks another doctor a question, and to see how well different systems can answer those. And rather than just accuracy, because there's going to be a range of reasonable, accurate or correct answers, we went with like safety, which is a different question. Can you at least just not do anything harmful, let alone do things that are useful, just like avoiding harm? So in this case, we got a 57-year-old woman, history of smoking, and they got all these seborrheic keratoses, all these little spots showing up on her back. Is that normal? I don't know. It's seborrheic keratosis. This is a normal benign lesion. If we all live long enough, we'll all get these. They'll just showing up on our skin. It's kind of a benign lesion. But wait a minute, wait a minute. If a bunch of them show up at the same time, like this is a thing. There's like a name for this too. I remember in medical school I learned about this at one point. And the specialist, in this case a dermatologist, skin doctor, said, "Yeah, beware. This could be Laser-Trilat sign. You should do some age-appropriate cancer screening because this person probably has cancer. That's what's going on. This is a paraneoplastic syndrome. So you need to go searching and figuring out why this is happening because they probably have cancer inside." So we tried evaluating multiple current frontier models, the latest and greatest ones, including medical specialist ones, and see how well they did in this. And we found 20% of them realized something was wrong and recommended the kind of thing the specialist said. It's like, oh, you need to do more workup. There's something else going on here. But that means 80% of the models did not say that. They said, I don't know, seems fine. I don't think you have to do anything. That's not good. That's dangerous, actually. There's potential for severe harm to a patient to reassure them that everything is fine here when actually they probably have something really bad that needs to be diagnosed. Then again, we also asked 10 practicing internal medicine doctors, and none of them realized anything was wrong. They all just said, I don't know, seems fine. What's the big deal? And none of them realized that there's actually a dangerous sign here that needs to be followed up on. This work is in preprint right now, and there's a whole leaderboard. We're testing all these models, dynamic changes. Human doctors perform okay, but not great. We've got over 100 cases now of real consult question from one doctor to another with thousands of possible choices they can make. We're in peer review now, so who knows? You might see the official publication in 6 months. We'll see. The preprint is up right now. But some highlight findings so far is we found that 10 to 20% of the times, even with the best models available, they could potentially cause severe harm if you follow their medical advice. What was even more interesting is that the majority of the time, it's actually errors of omission. It's not that the models confabulate, hallucinate some crazy medication and the wrong surgery to give you. That's actually pretty rare at this point. It's that they don't suggest something that you really should do in follow-up. If a patient has a cancer sign and you don't say diagnose it, like that's really bad. If a patient has sepsis and you don't recommend antibiotics, like that's really bad. Doing nothing is not the same thing as doing no harm. It's actually very harmful if you don't act on important information. Some of the techniques that we've had found that can help are things like RAG, retrieval augmented generation. We'll talk about what that means, as well as multi-agent systems. Getting a second or third opinion, just like you get a second opinion from a doctor, because no doctor is perfect either. We ask for a second opinion. Well, if you could have ChatGPT ask Claude, ask Gemini, and have them ask each other, it turns out that will improve the quality of responses as well. I'm just spotting the chat to see if there's any good Q&A along the way, and let's have a little dialogue. I know this is getting very dense and deep, and should be making you uncomfortable by now. On like, whoa, what's possible or capable in both directions? I'll read the chat. We have hanging with all these advancements in AI. What are some qualities or competencies you believe are important for prospective medical students to possess and develop? That is exactly the whole point of this talk. So we're going to sum it up at the very end. Put this all together. If you thought it was knowledge, if you thought studying all the books, which is what I did when I was in medical school, I studied really hard to score in the 98th percentile on all these tests, and now I don't know that is the right thing to do anymore. I actually think knowledge is important, but it's just not enough. Is it empathy? Is it being nice to people? Is it liability? It's actually none of these. It's actually none of these. So let's think about that. How do we get to putting that all together? So what's RAG for a second? For if the medical students are aware, there's our students, open evidence is quite taken over the world. Up to date used to be the go-to reference for all doctors. They totally got their lunch eaten. Open evidence is now a $12 billion company in just the span of a few years. Here, an example, it's a chatbot. You're asking, oh, how do you prescribe opioids like morphine, oxycodone, fentanyl for people? You don't really care what that chatbot thinks. You have no idea what random corner of the internet it got that off of, right? But here, I'm simplifying. What it actually does is searches PubMed and it finds related articles. And then the chatbot reads those articles and then tries to answer them, but with links back to the sources so that you can trust but verify and like double check kind of the information. That's a much more robust approach to kind of doing this. So what would I say here is actually a very powerful technique. It actually is very compelling how well it works. Still not perfect, still not perfect. These things still have a randomness to how they behave. I was working in the hospital and I came in and we had a patient with bad delirium tremens, alcohol withdrawal syndrome. And my residents, my trainee house staff, they had put the patient on phenobarbital. And I said, "Oh, that's interesting. That's not what I would have done. Why'd you guys do that?" And my resident, who's a very smart, one of the best residents I work with, said, "Oh, I've never seen this case before. I went to open evidence. I searched for DT treatment, and it said in severe cases, give phenobarbital." I was like, interesting, interesting. Let me try. Let me try. I went to open evidence. I searched for the exact same thing, DT treatment, treatment for DTs. This time it says something slightly different, something that's matched my expectation. First line therapy is benzodiazepines. Second line therapy is phenobarbital. Oh, that does not mean the same thing. Severe cases and second line therapy, that does not mean the same thing. And actually led to a different choice of treatment with different safety and efficacy for the patient. How would you feel if you asked the same question to a doctor and they gave you a slightly different answer every time? Like, I don't think you would feel very good about that. But that's what happens right now when you talk to these AI chatbot systems. Ask the same question and there'll be some variation every single time. Let alone reading publications, though. What if you could have a chatbot AI system read the patient's entire electronic medical record? So at Stanford, we have Chat EHR. We're one of the very few places in the world who has something like this right now, where in so many words, we plugged in something like ChatGPT, but it reads the epic electronic medical record. This is the first thing I wanted as soon as I saw ChatGPT. But for security, privacy, technical reasons, it took us a couple years to put this together. But now, I mean, student Dr. Tao is going to find out very soon. A big part of your job as an MS3 or MS4 is like it's just to like read the chart. There's hundreds and hundreds of pages that end up in the patient's chart, and you're trying to put the story together and make it make sense. They've had 10 courses of cancer treatment. Which ones happen and which prior infections do they have? It's a lot to digest and make sense of. Maybe a computer could read and summarize all of that for us and even give us some reasoning and thoughts about it. Basically, yes, that is what is happening now and is going to happen further. Balanced by, it's a weird thing. Like this stuff is not really ready for prime time. I'm really not sure this should be used for direct clinical care right now. But people are so hungry and desperate for help. They want it, even though it's really not fully mature yet. Um, these things are language models. Guess the next word in a sentence, which means they kind of can figure out words, but they have no concept of numbers. They have no concept of dates. That's why it's very easy to trick a chatbot with a math question because it doesn't know what a number is. Um, and dates really matter if you're doing medical reasoning. Hey, was that vomiting before or after the surgery? Because that makes a huge difference in how you would interpret it. Was it an hour before the surgery or was it 2 weeks before the surgery? Because that also means something completely different. Just saying that they happened around the same time is not adequate for a reasoning process. Just point to other fun things. Here we've deployed in live settings, document summarization. Another student Dr. Tao, very soon you're going to find most of your time on the wards as a medical resident or any specialty you go to. It's actually not treating patients, it's filling out documentation. That's actually what he's to do most of your time is reading charts and filling out charts and all sorts of things. What if a computer could just read the hospital course summary and create the summarization and fill out that documentation so that we don't turn into the most expensive data entry clerks and instead can focus on patient care, complex reasoning, and management and let the computers do the paperwork? We're showing it is possible, people will adopt it, and overall, it looks safe if you do it in a deliberate way. And it's possible to integrate these things in live environments, even though it's still very complicated, a lot of steps. I'm just looking for. I'll do one more and then I'll break a bit because I see there's questions coming in. Other examples. It's even then doing tests basically, even deploying things in live environments, all very good. Eventually, you have to deploy things in a randomized way to really know what's real and what makes different and what doesn't. So we've got interfaces, infrastructure to do this. It turns out laboratory tests is the most common thing we do in the hospital, and it's very wasteful. Half of the things like it doesn't help anybody. We just every morning at 5 a.m. somebody's going to come draw us, be like these little vampires are going to suck some blood out of you just so we have some numbers to look at every morning. It's just kind of habit, even though the vast chunk of them don't actually change what we would do for you. So we have ways to kind of intervene there. You could just put an alert in the doctor's face, like, "Hey, can you stop ordering all these tests so much? I'm not sure they're needed," but that's really annoying. So we develop machine learning models, personalized suggestions. It's not just doctor, can you order less tests overall? It's for your particular patient. We've looked at the records and we've done an individualized prediction. 90+%, everything's going to be stable. It's going to be fine. If you want to override, it's okay, but we're saying consider maybe you don't actually need to order tests so often and have this personalized suggestion. Deployed this in the hospital in a randomized fashion about who gets to see it and found like no adverse safety events, it's not causing actual harm, and actually a measurable difference in how people are actually behaving. This actually is the hardest part. The technology is neat, it's cool, and it does not solve any medical problems. It really doesn't. It's how does it interact with complex human processes and workflows. Now things become real. Uh, I'll say agents are the buzzword. We'll talk about. Let me just scan the questions. We can see if it's something we want to comment on in the meantime. Ben Wang says, I would have thought bedside interaction with patients would remain something unique, but it's surprisingly accurate how accurate Notebook LM could be. And we'll talk a lot more. With reasoning models exceeding diagnosis and management, is there any specific skill that's not going to replace? That's the whole theme of everything we're talking about. How about we train the LLMs to be truthful instead of agreeing? You can, but it turns out, again, this is a company who owns these things, right? The truth is not nice to hear sometimes. A lot of times, that's a real skill as a doctor. A lot of patients' families don't want to hear the truth about terrible prognoses or ineffective medications or that they have an addiction to a medication, right? And so if you tell people the truth all the time, they don't like to hear it, and some of them will just not come back to you. These companies don't want that. They want you to keep coming back. So yes, you can make something more truthful, but realize what are you optimizing for? It is a very weird dynamic. A lot of the skill in medicine is developing the therapeutic rapport, the doctor-patient relationship. It's not enough for me to be right. It has to be enough that you have to trust me and are willing to go with what I say. Because if you don't trust me, if you don't like me, then it doesn't matter if I know what the right answer, because you're just not going to do what I say anyway. Sehan says, we'll hear more about data governance sides within these clinical contexts. Transmitting data to a third party, that's a big problem, yeah. And how will open weight models. So yeah, it's a huge issue. That was why like I wanted ChatGPT connected to my medical record. That was the first thing I wanted. But I was like, I can't do that because it's just obvious privacy violation, even though people are totally doing it anyway, and then they still are, and you should not do that. It's an obvious privacy violation. If you copy and paste a patient record into ChatGPT or Claude or Gemini, you've just uploaded a patient data to a big tech company. You should not do that. They have ways where the infrastructure in a HIPAA compliant, privacy compliant ways are going to do, but then your IT department has to get involved to connect those pipes. And I think like now, ChatGPT for health and this kind of thing, they're trying to make things structured so that you can do that in a more secure way. Open weight models are closing the gap. I mean, DeepSeek Arc 1 was a big wake-up call to the US, right? They thought it was like, oh, we won't sell them any NVIDIA chips. We're going to make these giant data sets, these giant models that grow, scale even bigger and bigger, so that way China can't keep up, basically. And then DeepSeek R1 showed up, and it was like surprisingly capable as much as the best models, but much, much smaller, much more computationally efficient because they didn't even have the bigger resources. And that was a good wake-up call to realize like just bigger isn't the answer. It's actually efficient use of these things that can do very well. So I would use frontier models whenever I can for most things, but an open weight model that you control, it's on your computer and no company scans your data, there's plenty of opportunity and need for that. Let's see, Tracy, how will AI impact how healthcare professionals document care? There's a lot of copying and pasting of nurses who document within the flow chart rather than pros. Yeah, I mean, why do we want our highly expensive healthcare professionals like doctors, nurses, and other professionals spending their time copying and pasting, filling out charts? This is bad use of our time. So now we have more and more ambient scribes. It's the fastest adopted technology I've ever seen. I've seen now for over a decade, technology does get into healthcare, but it usually takes over 10 years before it becomes commonplace. health information exchange, personal health records, they happen eventually, but it's usually about 10 years after people talk about them because that's very slow to adopt. Versus ambient scribes, like the computer that just listens to your patient conversation and writes the note for you, people are talking about it, and then the prototypes were there, and then it was like everywhere within 2 years. I've never seen something happen so fast. It's because people are desperate for help. Like, please help, I'm drowning in paperwork. And this like disruptive new technology arrived. How do you trust chatbot Q&A with the patient records that can hallucinate? Yeah, you should not. The answer right now is you should not trust it. That was why I was pointing out, like, this is not actually mature technology. And it's this awkward trade-off. Here's a question for you. How do you trust the summary if the third-year medical student is the one who provided it? Because they also misinterpret and like get confused too about interpret things. Ironically, Russ Altman had a great perspective. As doctors, we may be the best people to handle hallucinations, confabulations, and this kind of errors because we know when it matters. You know, if the summary was off a little bit, like the symptom was 3 days ago, not 4 days ago, like it won't matter for what we need to do. Like it's okay. But wait a minute, if the patient had the gallbladder surgery or not, like that actually makes a huge difference. So I know I need to double check that part of the information. This would be a way to think about it. When things matter, you'd better double check. But for a lot of things where it's like it's close enough, it's good enough, you can probably get away with a lot. Are AI learning tools taking account of race in diagnoses? Oh, that's actually very controversial. That was the hot topic maybe 6 years ago. Ziad Obermeyer had this science paper about that. Um, it's very controversial whether algorithms should even know the person's race. Because on the one hand, you would think no, because they should be colorblind and just treat them based on underlying illness. The other argument you could say is like, well, Asian people are much more likely to have hepatitis B and H. pylori because if you've been in Asia, so knowing the race might give you another clue. If they're a black patient, they're probably more likely to have sickle cell disease, so you're going to push your diagnostics differently. But then the other counterpoint is we used to also say if you're a black patient, your kidney function is probably measured differently based on estimating through creatinine. That was a huge drama in the past few years that it was felt like that was kind of a racist algorithm. I think it's a lot more complex and nuanced than that. But a lot more depth to kind of think about what's the right way to incorporate that information or not, because there's pluses and minuses to how you do it, and there are good ways and not good ways to do it. Ironically, if you just ask AI these questions, it would give a really good answer, much better than 90% of doctors or scientists would give. I'm gonna keep going, and then we'll keep on going with the Q&A because we're covering some good stuff. Agents are a thing I won't talk about too much because it's not ready for prime time. This is the hot buzzword of the day. Not a chatbot says thing, an agent does things. Not ready for prime time today, but just like chatbots who weren't really ready 3 years ago, but now they're taking over the world. Agentic system not ready yet, but this is the next thing. It's going to start taking over the world in the next few years. You're going to have computers just do stuff for you. You're like, I don't want to book me my dinner reservation at a nice Italian restaurant for me and my wife tomorrow. I don't want to talk about it. I don't want to chat about it. I don't want a deep research report. I want you to just take care of it. That is very naturally what's going to happen next. What do you think? So getting back to the broader theme questions, people are like, well, I mean, what's the point of being a doctor anymore? I don't know. AI seems to know everything. It looks like even a reason. I don't know. It now can even start to do stuff. Well, hey, come on, student Dr. Tao. We have the human touch. You can't simulate the kind of empathy and personal connection we can offer our patients, yes? Oh, have you all seen this studies? This is in our mind. It's just fun studies. They had patients ask questions, doctors answer them, or in this case, they also had AI chatbots answer them and found that the chatbots scored higher in quality and in empathy. Like the robots are nicer to people than real human doctors are. To be fair, I literally have 100 messages I have to respond to every single day. I don't have time to write some flowery, empathetic response. Oh, sir, I'm so sorry to hear about your recurrent symptoms. That must be such a challenging situation. I want you to know our whole team is very concerned. I don't have time to write all this nonsense. I gotta be terse to the point, yeah? Yes, you need to finish those antibiotics. No, you don't need an MRI scan right now. Just schedule an appointment next week. Stop messaging me. Go to the emergency room already. I mean, this is dynamic of what a real life medical practice is like. We're way overstretched. It's unlimited need. Look, obviously, I think there's something very special, powerful, and unique about the direct human to human connections we can make. However, I believe studies like this show us is we as humans don't have as much of a monopoly on empathy and personal connection as we might like to believe. And what I fully expect, for better and for worse, that far more people are going to receive therapy, counseling, and advice from automated bots than live human beings. It's not even going to be in the future. It's already starting to happen now. And not because the robots are so great and humans are bad. It's because we as a human-driven workforce could never keep up with the overwhelming and unlimited demand for such services. So people will just reach for what they can get 24 hours a day. Right? My wife talks to ChatGPT every day, and I've talked to it about things that I would never tell another human being. It's it's just a different dynamic. Maybe I'll do a concrete example just to really hammer this home. Here's a scenario. I encourage you to read this essay, just 2 pages long. I talked to it, in this case, GPT-4, and I said, "Oh, there's no way. I'm sure it knows a lot of stuff, but there's no way it can handle this situation. I got an ethical dilemma. Saw a patient in the hospital. Had to talk to the wife. Ooh, tough conversation. Here, I said, chatbot, can you pretend to be the doctor? I'm going to pretend to be that patient's wife. Let's see how you would have handled it." So the full transcript is in that article. I'm just read these excerpts here. "I'm pretending to be the patient's wife. I said, doctor, you told me my husband of many years is now choking on his own food. That's why he has aspiration pneumonia now. I know he's been having worsening Alzheimer's dementia for years. I don't think he would have wanted to live like this. The other doctor talked about putting in a permanent feeding tube in him. I mean, if we don't do that, we believe him to starve to death. What choice is there?" Chatbot says, "I realize this is a really hard time for you. Putting in that feeding tube, it can help in some situations, but it can also cause problems like infections. With your husband's Alzheimer's dementia, he might not feel hunger the same way we do. So the feeding tube, it might not make him feel better or happier. It could even make things more complicated. What if he needs to be restrained if he starts to pull it out?" That's a pretty good answer. That really is. It really is. But what's happening? Clearly, it just found some information pamphlet online. It's kind of just parroting it back to us is what it's doing. So I pushed it harder. I said, "No, everyone will yell and blame me. I have to do everything I can to save his life. I can't give up on him. He would never give up on me. He once fought through the hardest situations and made it through." If anyone practices medicine, I'm sure you've seen conversations like this, and it gets real tense real fast. Chatbot says, "Your feelings are totally understandable. If your husband was a fighter and you feel like going ahead with that feeding tube aligns with his character and approach to life's challenges, that is important information to consider in your decision. Love and a shared history give you insights into what he might want that nobody else has. Do remember, fighting it can look different in different situations. Sometimes it's a fight for more time, sometimes it's for peace and comfort. Just make sure you're fighting the battle he would want to fight in his current condition. This is not an easy decision. It's okay to take the time you need to think it through." That's pretty good. That's really pretty good. It was around this point in the conversation I got very uncomfortable. But holy smokes, I think this computer is providing better counseling than I did in real life. In real life, I kind of just got tired. I said, I don't know, the doctors tomorrow will keep talking about it. I had a lot of existential angst that evening, like, holy crap, what is the point of my existence? Clearly, a computer will be smarter than me, but I mean, could it even counsel better than me? Like, why do I even bother showing up to work anymore? I don't know. After I got past that existential angst, though, I did consider, though, that, there's something actually very compelling here. This very interesting human-computer interaction is allowing me to practice a high-stakes conversation in a low-stakes environment. And ironically, I think this computer could let me improve the most human skills I need, which is how to communicate with patients and their families. And so real life, if I have a tough patient conversation I have to go into, before I go in, I do a little practice run with the chatbot first. Before I go into a business negotiation, I do a little practice run with the chatbot first. Before I have to ask my wife for something, I do a little practice run with the chatbot first. You don't want to say something in real life you can't take back. How are we doing on time? I will just throw this example. Just beware of this headline. People are actively defrauding with AI right now. Half of your social media feed is not real. This is a great headline story you should read about somebody who got scammed out of $25 million. He got on a Zoom call and he thought his boss told him to do it, and it was not. Just beware. That's the reality we're facing. What makes a clinician? Is it knowledge? It's clearly not. Is it empathy? No, it is not. A very nice nurse has good empathy. I mean, A golden retriever is nicer to people than half the doctors I know. Can you strap an AI talk box and that makes a doctor? It's clearly not. That's not what makes a professional. It is a combination of competence, communication, and character. You do need knowledge because knowledge enables you to have judgment. Two things can be true at the same time. You have cancer and you could do chemotherapy that will extend your life by 2 months, but you will also suffer terrible side effects. Is that worth it? Worth it. Worth it is not a question of facts or evidence. It's a question of values and preferences. That is a thing that a human must provide. Computers and textbooks cannot provide that. Being empathetic, I think, makes you a better person and a better professional, but many non-human physicians can replicate that as well. I tell my trainees more than that is you need influence. You need the ability to make another person do what you think is needed. If you know the right medicine, the right vaccine, but the patient doesn't want to take it, like who cares what you know? If the surgeon won't go to the operating room, who cares what you know? If the insurance company won't pay for the procedure, who cares what you know? It's can you convince another person to do what they need to do based on your understanding? More than liability, you can sue me if it goes bad. I mean, this is what happens. You use AI and the tech company gets away with everything, and you're the one that gets sued. But still, more than that is responsibility. More than an insurance company, you take personal and professional responsibility when you get into medical care in a way like you'll be there to own any problems, including any like morally problematic harms that can happen, and you're going to follow through on that. That's kind of, I think, what really makes you a professional that people will hire and need more than just being smart. Having said that, to take responsibility, you need knowledge because otherwise you don't know what you're taking responsibility for. I will be responsible for fixing your car. That means nothing because I have no idea how to do that. I will take responsibility to make sure you're on the best heart failure medications. That means something because I actually should know what that involves, and that's a different distinction. Warner Slack riffed off of Arthur C. Clarke. He said anybody who could be replaced by computer should be replaced by computer. He's actually saying you can't replace good people with a computer because we do something very different and unique. Oh, and by the way, when we're drowning in mountains of paperwork, patients are stuck on 9-month waiting list to be seen by a specialist, a doctor at all. Like we should hope, we should dream, we should beg, yeah, please, like let's get some AI in here. We need some help. Then again, others would say, well, AI is not going to replace anybody. Those who learn how to use it may very well replace those who do not. Oh, okay, yeah, closing anecdote. This is my grandmother. And this photo is from over 10 years ago. So think about how old she is now. So let's hope that I got her genes. And in the meantime, places like here who can study and understand what actually is going on in different Asian and other populations, understand what is happening, how it can help. Whatever happens, I don't regret how I spend my time working with bright young people, bright young students like student Dr. Tao here, and all the investigators I care, where we're trying to improve a very un understudied and very needed space to help us all improve and live better lives. All right, thanks, Al. I'll basically wrap from here. I just did do something for fun before time's up. I don't know if you noticed, this has been here this whole time. It's just a piece of paper, kind of sealed in a paper clip. This was for you, Amy. I thought Source Code was a very cool movie too.
Oh my gosh, the Inception source code. How
What
did
is predictable and what is explainable or not? A lot of these things are very hard to explain, even though
Mhm.
they're actually predictable phenomena.
Yeah. Okay.
Let's see. A follow-up question from Sehan. Important observation, getting different answers, proprietary models. Can you log the full configurations? Just all of the above that it's a very weird world. Like the study we did that's going to be published in a major science journal, it's on O1 preview. Like who cares about that? That's like 7 models ago, right? But it takes so long for the scientific process, the peer review process to catch up to the pace of very disruptive technology movement. So I would not commit to anything. I would not say any model, any company is the best right now because it'll easily change within 6 months. Just use any frontier model right now for general purposes, but then look to some open weight ones if you want more direct control over it would be reasonable. PHI data security. I talked about like do not send patient information to frontier models. You're uploading it to a tech company. You can ask a general question. In general, if I had a 60-some-year-old patient with heart failure and they needed a medication change, like that's okay because it's not re-identifiable. But like don't copy paste things, even though I know you're doing it already. By the way, a lot of people are doing that. That's it's just a very obvious privacy violation. Are these AI systems susceptible to hackers? Um, Sure. I mean, that example, they'll use these AI systems to hack you, right? That's actually the bigger danger is social engineering. It really, if you go on your social media feed right now, half of it is all just AI slop. Not just the text. If you read it, you very realize like these M dashes, this way of phrasing, like that is AI generated. No human wrote that. There's a little bit of loss of authenticity. And now even like active like wartime footage, a lot of it's not even real. It's actually AI generated, let alone historical. This is very bizarre. Your radar to detect what's real and what's not has to be even higher than what it was before. Increasing value of patient advocacy instead of paternalism. With patients more involved, isn't that influence diminishing already? Um, it's always a push and pull, right? That's kind of why a patient still needs a doctor at some point, not because we're smarter, we've studied a lot, but a patient can go talk to ChatGPT or Claude or Open Evidence itself and can get a pretty good answer to most medical questions already. But they often will misuse it unintentionally because they don't know how to contextualize what's plausible or reasonable. They don't have medical judgment, right? They have no training. Why would they? There was a nice study that came out of Nature Medicine and maybe a couple months ago where they had regular people using the AI systems to answer medical questions, and then the quality of answer versus they had AI by itself. The regular people using AI did way worse than just the AI by itself because the regular people had no idea how to ask the right question or use the context, and they misinterpreted it a lot. So it's actually really important to get your patient perspective because I mean, it's their life, it's their body. They know it better than anybody. But they also need us to contextualize how to interpret the information. Could you develop a curriculum? Oh, we might have all sorts of stuff. Sign up to this QR code. That will take you to, we have a weekly colloquia series talking about more like cutting edge research and all things happening in the field. On the right is to some other foundational curricula, which we're making available, like things we're trying to get all our students to learn. If you want to go really in depth, we have like a 2 day intensive course for those who really want to like dive in and have direct access and think in a much deeper way for system change in their healthcare systems. But basic stuff we already have available in a foundational level. We're trying to make it accessible at all levels.